Good evening and welcome to our presentation on the impact of healthcare funding on local communities. I'm Stephanie Van Ortstrand, an organizing member of Voices from the Prairie. Every day we are inundated with information about medical care, the associated costs, and the legislation that impacts both. We are honored to have such a wonderful panel of community healthcare experts to help us better understand the complexities of healthcare, finance, and what it means for us here in the Illinois Valley. Our facilitator for the program is Deb Rausch. Deb is a registered nurse and a federal navigator with the Patient Innovation Center. As a navigator, she provides education and enrollment assistance to consumers related to the health insurance marketplace and with Medicaid. The Patient Innovation Center is a nonprofit that receives a federal grant to provide navigator services in 35 Illinois counties, including Bureau. Without any further ado, I will turn it over to Debbie. Thank you.
Good evening, everybody, and I want to join Stephanie in welcoming our audience as well as our expert panel members to this evening's presentation. This is the second healthcare panel discussion convened by Voices from the Prairie over the last few months. Voices recognizes that the topic of healthcare dollars is both of high importance to many people and subject to frequent changes on many levels. Because the topic is so important and vast, the group is also considering other panels and educational forums in the future. We hope you will consider joining in those discussions and watch for information about future healthcare-related events. Before I introduce our panel of experts this evening and get into the meat of tonight's program, I want to put some perspective on what we are here to discuss tonight and where it fits in the larger discussion of healthcare and dollars. If you take a look behind our panelists, you won't see the word cloud, but I'm going to put it up there. If I can get it to work here. Okay. Whoop. No, not going to work. So Margaret, maybe Margaret.
There we go.
There it is. All right. But it could be titled Healthcare and Money. Whether you say pay, spending, cost, value, funding, these are just a few of the words that get tossed around related to healthcare and dollars. It can be quite confusing, and that makes it difficult to have frank conversations and to really identify the core issues. The following paragraph from a 2012 article in The Atlantic says it better than I am able. It's entitled, What Healthcare Costs Really Means. Framing our problem in terms of cost is a misrepresentation of the real challenge, and how to slow the increase in spending. And the article goes on to say, let's take a look at what the phrase healthcare costs really means. It turns out everybody uses the term to mean something different. Politicians talk about costs in reference to federal and state spending on healthcare. When hospital administrators and physicians talk about healthcare costs, they are usually referring to their cost of production, the money they spend on the resources needed for to care for patients. When business leaders use the term healthcare costs, they really mean the price of insurance or the amount that they spend on their employees' healthcare insurance plans. Meanwhile, everybody bemoans out-of-pocket costs, the amount patients must fork over at the doctor's office and pharmacy counter over and above whatever portion of the bill their insurance covers. So cost is just one more of the terms that means something different depending upon who happens to be using it. And that is part of what creates confusion. The same could be said about the term funding, which is the topic of our conversation and what our panelists are going to talk about this evening. So tonight they are here representing one very important perspective in this discussion, that of healthcare providers, our local hospitals, physicians, and public health providers to be exact. They've been asked to discuss funding of local healthcare providers and how that impacts care of patients in our local communities. In addition, Pat Scow, one of our expert panelists, will be able to provide new information and insight on recent policy and legislative developments that directly impact funding of our healthcare providers. Each panelist will have about 10 minutes to speak, and then that will be followed by a question and answer session. So if you would please, for the most part, hold your questions unless you just can't stand it until all of our presenters have had an opportunity to speak. Okay. All right. So first off, I'd like to introduce Pat Scow. Ms. Scow is the Executive Director of the Illinois Critical Care Access Network, known as ICANN, the first statewide critical access hospital network. Established in 2003 and comprised of 55 critical access and rural hospitals, the network provides a number of hospital support services and educational programs, as well as managing the Medicare Rural Hospital Flexibility Grant, the Small Hospital Improvement Program, and other grant programs on behalf of the Illinois Department of Public Health. In addition, Ms. Scow is also the Executive Director of the Illinois Rural Community Care Organization and works with Dr. Davis in that organization. Hello. She serves on the National Rural Health Association Rural Congress and Government Affairs Council and was recently elected secretary. In addition, she is also a member of the Accreditation Association for Hospital Health Systems Board, is a recent chair of the Technical Advisory Services Committee for the National Resource Center, was co-chair of the Illinois State Health Improvement Plan Implementation Coordinating Council. Wow, I got that one out.
That's just
From 2010 to 2015, and served as chair of the local health board for more than 20 years. She is a fellow of the American College of Healthcare Executives. Ms. Scow has more than 35 years of clinical and rural hospital administrative experience, including her 10 years as vice president of Prairie Memorial Hospital, and holds a Bachelor of Nursing degree from Illinois Wesleyan University with a Master's of Science from Northern Illinois University. She has received numerous awards, including in 2013, the Calico Rural Leadership Award bestowed by the National Rural Research Center, the top 25 women in leadership for Peoria, and is a woman of distinction in the Illinois Valley. Was recognized as the 2014 Illinois Rural Hero by the National Center for Rural Health Professions, University of Illinois School of Medicine, Rockford, and the National Rural Health Association's President Award in 2015. Ms. Scow, though she resides right here in our town of Princeton, is well known as a national speaker and facilitator, and has just returned from the National Rural Health Association Conference in Kansas City, and will share some of the latest details with us this evening.
thank you.
Thank you.
Is that good?
Yes.
Okay.
Yes.
Thank you.
Real close.
That's
Yeah.
way too much. Thank you, and it's a pleasure to be here. And you know, I know we're against the Cubs game, and so healthcare is really important when you're giving up your time here tonight. So since my background is a little more from the state and national level, I'm going to talk broadly about healthcare and try to bring it home and plant some points that I'm sure that Hector and Dr. Blanford, Annette, and Dr. Davis will cover here shortly. So it's like I said, this is really an ever-changing topic with healthcare, and I thought Deb's introduction with Atlantic was very apropos because we all look at healthcare differently. I'm going to talk a little bit at the beginning about the importance of rural healthcare. You know, that's where we all live in our rural communities, and it's really mission critical that we are involved and we care about what happens because we want to keep healthcare locally. You know, we really want these fine people to be able to provide healthcare, and if we don't watch how healthcare is provided and keep and support our local community, it won't be there. So it's very important, and I believe that rural healthcare really is the infrastructure for our country. You know, 80% of our country is geographically rural, and 20 to 25% are the people that reside in rural. So we have a big population, regardless whether you think that or not, that really reside in rural. And so it's very important that we take good care of our rural community, and they do a fine job. I'm just going to step back in time a little bit and preface our discussion, because in 1965, the question always begins, is healthcare a right or a privilege? And that's what we're all talking about. Do I deserve healthcare? Do I not deserve healthcare? Should it be a state responsibility? Should it be a federal responsibility? Should it be my responsibility? Well, it started in 1965 when the Social Security Act enacted Medicare and Medicaid. And in that, it allowed, seniors to have Medicare, and it allowed people that didn't have insurance, that needed, and under a certain poverty level, to have Medicaid insurance. And so it provided some basic coverage at that time. And so then, in course of time, it's expanded, of course, to what we have, the nice Medicare coverage we have today, and we've extended Medicaid services to many, many people. Right now, Medicaid, 1 in 5 people are on Medicaid. Hard to believe that. 30 million of them are children, and 7 million are elderly that reside in our nursing homes. What's interesting about Medicaid today is that it's become the insurance for the working poor. The insurance for the working poor, because of all this healthcare debate, and it's been a really challenge. But as Medicare and Medicaid came on in the scenes, then another important aspect entered the scenes in 1986, when it became hospitals' responsibility to take care of a patient regardless of their ability to pay or who they were when they entered the emergency department. So in other words, we've all had a right to health care to some capacity, a right to immunization, but it's the quality and the quantity and the amount of health care available is really the challenge there. And just because you have access to the emergency department doesn't necessarily mean that you're going to have good health care altogether, all the way around. And so it's real important to keep that in mind. And so there are a lot of things that also happened. Then in the 80s, Lee Iacocca, who ran Chrysler, was very upset about the cost of health care and tied the cost of an automobile to health care. And really said that, the reason my automobile costs too much money is because I'm paying too much in health care. And so that was really the biggest statement about insurances and the cost of health care. And then also about the same time, then the federal government limited the Medicare program as far as hospital stay. It used to be you could come in and stay in a hospital for 90 days, go home a day, and come back and stay another 90 days. Now, nobody gets to do that today, right, Annette? But anyway, they found that the reimbursement and the admission program in the Medicare program in the early 80s was just growing out of control. And so just like the cost of automobiles, it was the cost of healthcare hospitalization that added some control. So over the course of time, as we expand programs, there's cost to the public, cost to your individual pocket dollar. So, and then, we also have other programs that are being produced, such as prevention programs as far as immunization and all these things. And they're wonderful, but they do, provide a cost. Look at dental. Remember how dental health has improved over the years, with fluoride in the water, right? Different things like that, fluoride treatments. And so we've done a lot of things from the national level to help. And so really, it's always been a national problem from centuries, public safety and health care. But because of the high cost that you've talked about in many capacities, it's become the debate today. So when 2010 came around and we passed the Affordable Care Act, with that, we knew that healthcare was in trouble. Medicare, we knew the cost dollars, and Medicaid, and we still had close to 20 to 25 million 25% of Americans that didn't have health care coverage. And so that's what came about with that. So it was really another critical time, and why they did and enacted the ACA. Whether you like it or not, publicly like it or not, it's expanded health care and provided some resources. And once again, it's moving that privilege of health care up to a higher point of equalizing it for others. Now, under the Affordable Health Care, even though we've had some changes in the marketplace, and we'll talk about that, nearly 95% of Americans have health care coverage, either through Medicaid, the marketplace, or their own personal insurance, or Medicare. So, we have made strides, but it's also cost us money. And some of the problems have been how they've enacted the marketplace. It's not perfect, but it was a start. And then Medicaid expansion. I heard today on the news about the cost of Medicaid expansion. You know, you have now in 2007, you know, since 2007, the number of enrolled in Medicaid has doubled. So think of Illinois paying its bills. If our Medicaid rolls have doubled in 10 years, what's it going to be like in 5 years? Or 8 years when we have to pay our debt? So that's the, you know, it's wonderful to expand Medicaid, but we have to think about how are we going to pay for it. So these are the challenges that are really out today. So, and the challenge also is how we put these bills out there, you know, how Congress proposes bills, because, you know, we have to figure out how to pay for this. And what's an interesting statement, you know, the House passed the American Health Care Act in May of 2017, but the Senate couldn't get their bill passed, okay? They couldn't get that done. So, you know, with that, you know, what are you going to do? And when you go out and you talk and these bills are produced, or they put them out there, what is best said and why it's so hard to make a change is people really don't remember expanding health care benefits, but they remember when somebody takes a health care benefit away from you. So that's why when you propose an idea, if you're a congressman or a senator and you put these bills out there and it takes away things, that's a lot of heat. And you have to deal with public voting. And are you going to stay? And so it becomes a very complicated process, because remember, once again, once you take away something, people remember that, whether it's good or bad, and so that's why there are tough choices out there. So as I said, in May of 2007, House passed the AHCA, and really what it did is kept a lot of the marketplace in place, but what it did was eliminate some of the tax and increases the health savings accounts, and it also created some high-risk pools. But what it did was to fund this is they started to take money away from Medicaid. So if you take money away from Medicaid, which we're all taking advantage of it, how are you going to pay for these people that don't have insurance anymore? So that was it. So when the Senate tried to pass their bill, that was the issue of Medicaid, and why a lot of healthcare providers were very much against it, because we've got these people that are finally getting health care, consistent health care, not just a trip to the emergency department. So that becomes, you know, so the Senate couldn't get anything passed. They proposed the Better Health Reconciliation Act, which all have different variations of tax subsidies and keeping the plan, or offering, you know, insurance programs that cross state lines. Then a few weeks ago came the Graham-Cassidy bill. And if you're not familiar with the Graham-Cassidy bill, and what it did was it allowed, once again, the states to decide whatever they wanted. And then it also took away preconditions, pre-existing healthcare conditions. So that's a deal breaker for a number of people. Once again, it's throwing the management of Medicaid back in the states, and it's creating, eliminating pre-existing conditions. And so that's a part of the problem. How do you do that? How do you take that away? And I was sitting around a table of colleagues from across the country, and we were talking about, with rural health, about pre-existing conditions. And, you know, I'm sure, you know, I'm healthcare, yeah, we need to cover that, you know. And nobody really dismisses covering somebody that's born with a deficit, or somebody that really has, you know, something that happens to them. But I had people around the table that are healthcare providers, and they say to me, well, I don't feel I should have to pay for somebody pre-existing conditions because of poor healthy behavior. Poor healthy behavior. And that becomes the issue with pre-existing conditions. Because sure, you know, somebody that has a, you know, a child, or, you know, like with Kimmel, Jimmy Kimmel with his case with his infant child that had, you know, heart defect. But it's those with behavioral issues. So those are issues that people have to deal with when you go in and pass this legislation. And just the other day, yesterday, another bill appeared on the horizon. And that was produced by Lamar Alexander from Tennessee, a Republican, and Patty Murray from Washington, who's a Democrat. And this is the one that's bipartisan. All these other bills, if you know, the House bill, that was all Republican. The Senate bill, the original one, the Better Health Reconciliation, was Republican, and the Graham-Cassidy is Republican. This is the first one, is the bipartisan one. And this is the one that seems to be more in line with President Trump. And it's to stabilize the marketplace, and once again, it throws flexibility back to the states. Now, think about, I'm not picking on Illinois, but we haven't done very well with our budget. Do you want the state of Illinois to totally manage all the health care dollars? Okay, so that becomes the issue there. And it provides some flexibilities. It once again allows insurance to be sold across state lines. And I think we talked a little bit about that at the last conference. But anyway, so these are some of the issues, you know, when you have to determine what the bill is. Now, there are now people out there looking to sponsor Bernie Sanders' bill. And his bill is a single-payer system. 5 years ago, nobody would talk to you about that. Now they have 17 co-sponsors of that. So now it's not going to pass now, today, or tomorrow, but many see that coming in the future. So the issue is not, you know, we all want health care, we all want to cover people and take care of people, but it becomes the issue of payments. What do you take away to pay for expanded Medicaid? Do you tax insurances more, higher premiums? People that have better health care, better premiums, do you tax them for that? You know, these all become the issues, and it goes back to the statement, once you provide services for people, people remember who take that service away. So, you know, on top of all these different bills out there, and these are in the Senate, what has to happen, since there's a bill in the House, if we're going to change, repeal, whatever it is with health care, there has to be a bill come forth from the Senate. Then the two bills have to be reconciled, and then one bill passed altogether. And then that would, of course, then you would look for executive order, then the president to sign that. That's the only way health care can get changed. The House has passed there, but if the Senate doesn't pass that, there's no repeal, replace, whatever there is with the ACA. So Trump dealing with all that, he's going to trump up here. And so he has released his executive order, which adds another little twist to the whole deal, now allowing state association plans. And what they are is groups of people can come together and form self-funded programs and create their own health plan. Now, how are we all going to manage all that? Doesn't that sound like fun? And it would keep now the ACO subsidies. You know, 2 weeks ago, Trump said, I'm going to get rid of all the subsidies, all the work for the marketplace. That's why nothing's really happened with the marketplace. They really thought it was going to go away. And so that's why been all these delays, and most of the people don't know too much about it. So here you've got all this waffling going on, these ideas, and then they waffle, ideas and waffle, is just because of all these particular issues of paying for it. So moving forward, and I brought some handouts on Medicaid expansion, who did, and the problems with some of the marketplace, we can take that later, is particularly for rural communities. Do you realize many counties across the country do not have one market plan offered for their county? They're in rural counties and nobody wants to go in and cover them. So what are they to do? So that's some of the other discussion as you look into the marketplace. The other issue has to do with how are we going to really improve healthcare. And we've got some other issues about big pharma, the cost of drugs. All those things have not come into play. We've got 82 hospital closures since 2010, rural hospital closures. We talked last time, we had one in Illinois in Streeter. And that's why it's very important to take care of your health care locally, support our fine people. And so in these health care bills, there's nothing really set aside for rural. You know, a lot of it's pushing bigger and better, bigger and better. When that happens, sometimes rural is left out. So I'm glad you have the Prairie voice, because those things are really different. So some of the changes that we're trying to do without legislation, and a lot of that's happened, these people are involved in, is accountable care organizations. And what we're really trying to do is better manage health care. With the ACA did one very important thing. It helped us think about health care differently. And that is that we need to increase the individual cost, your individual cost of health care. Make it better so that you're healthier and that your care is provided more efficiently. And then overall, we're trying to do population health, which the health department and others take care of it. So we're trying to do things to lower the healthcare costs without having to go around. So we're also going to move to global payments and single payer things. So there's a lot of things that we're really working to do. What I try to do is lay out kind of the history where we are today, the challenges of making legislation changes, and some of the great things that are happening today that we think we can do behind the scenes until other things take place. So let me pass it to Hector. Did I segue to population health for you?
That was a great job. Yeah, thank you. And I apologize. I didn't use the microphone earlier, but I will from this point forward. So I want to now introduce Hector Gomez. Mr. Gomez is the Fiscal Director and Assistant Administrator at the Bureau County Health Department. He completed his degree in Business Administration with a concentration in accounting at Robert Morris University. Mr. Gomez has served in the military for 27 years and has been at the Bureau County Health Department for 11 years, since May of 2006. He and his wife, Margaret, have been married for 24 years and have 2 children, Hector, who is 19, and Margarita, who is 17. Okay, Hector, thank you very much.
First off, I want to say thank you for having us here. I'm going to talk a little bit about what the health department does to start off with. The health department, as Pat has said, we are more or less a population, and we try to go ahead and prevent diseases, either through vaccinations, through our environmental health programs, which inspect restaurants, have to deal with, make sure you have safe water to drink, and also to do septics, to get rid of waste. One of the challenges that we have had at the health department also is that we have a dental clinic, which we have had, I would say probably for about 19 years or so or more. The challenges has become that the health department runs strictly on a lot of grants, and those grants a lot of times go away from the state or they get reduced. What happens with that, when that does, is that it eliminates sometimes certain positions from the health department, which require the grants to be able to go ahead and provide those services. Those services, for example, like what we're talking about, we have WIC, which is Women, Infant, and Children. We provide nutrition, and we provide breastfeeding and counseling and stuff for moms, breastfeeding moms. We also have vaccinations that we provide for 2 different categories of Medicaid. One of them is Title 19, which is strictly Medicaid. In other words, they don't pay no subsidies, and those programs are called Vaccine for Children's programs. Other clients that also qualify for those are anybody that's underinsured. In other words, their coverage doesn't cover vaccines for whatsoever, or they have no insurance at all, which their population does not have insurance. And we provide those at a very low cost because the state actually provides those for us. And, so we provide just an administration fee of $12 for those. What has happened for us over this time, for all these grants that have totally decreased, is that we have had to look at different ways to be able to go ahead and still provide services to the community, provide vaccinations. So we have done several things. One of the things that we have done back in 2013 is that, along with the Illinois Department of Public Health Association and 12 health departments, were a pilot program to be able to go ahead and actually register as providers for immunizations. To be able to go ahead and provide immunizations for everybody that was insured, it wasn't covered from the population that we can provide vaccinations for, to include the ones for the Medicaid that were Title 21. Title 21 is a program where they're on their Medicaid, but they actually pay premium and they don't qualify for the VFC vaccine. So they would have to be vaccinated through vaccination that are privately purchased. So we did that, and before that, a lot of the health departments couldn't actually register because they did not actually have a provider, they didn't have a physician on staff. So without that, a lot of the insurance companies did not actually want to be, for you to be a provider for them because of the difficulty of it. And so the Illinois Public Health Association ended up creating this program, which is when one of our navigators that was here then started, along with myself, to be able to go ahead and become registered providers for all the insurance companies to be able to purchase our vaccines and be able to go ahead and immunize them. The grants, again, it shortened our staff, so what we did also, just about a year and 8 months ago, we also ended up partnering with Marshall County. What it did is, it allowed our staff to be, do several things. It allowed us to go ahead and be cross-trained. It allowed job sharing, so if Marshall County needs a nurse, or Bureau County needs a nurse, we can actually send somebody from Bureau County or Marshall County down there to be able to provide the services, so that all the population can get their vaccines, and they can get with coupons, they can be seen. One of the other things that we have done in the health department, we have had, again, dental services. The dental services have been a challenge. We've had a dentist up to like April of this month, when our dentist was had to leave for medical reasons, and we haven't been able to get one. One of the reasons why it's hard for us to get one is the high cost of dental. To be able to go ahead and actually have a provider and to actually provide the services. Medicaid's a great program for all those that don't have any other insurance, that they fall way below the poverty level. However, a lot of the reimbursement rates for Medicaid through the dental program are not very good. Several years ago with the Affordable Care Act, they actually had a program specifically made for clinics like ours, that they would reimburse you for the cost of dental care. For example, if the dental care was 1.62 higher than what your actual were getting paid or reimbursed through Medicaid or private self-pay patients, they give you reimbursement based on a formula that they actually created, this thing specifically for it. So we ended up having to subsidize our dental clinic through all those years with that program from the federal government for the Affordable Care Act. Right now, we still have a challenge to be able to go ahead and have dentists and provide the services that we need to provide for our population that we're still actually searching for, and looking at other alternatives to be able to get a dentist at least once or twice a day to be providing the services. Our vaccines, those are provided, those are locally purchased through the health department. What we do is we charge for specific, to cover the vaccine for one, and to put an actual small administration fee to be able to cover the time and the cost that are associated to be able to process those payments, to be able to give the shots for the nurses paid. Right now, we're still looking to see what the Title 21, is what the state did, and this is just in the beginning of July of this year right here. They ended up not able to give us any more vaccines for Title 21 patients. So they ended up giving us what they call it 317 to be able to cover those vaccines, the patients for Title 21 for a certain period. They didn't really have an actual reimbursement rate of what they were going to pay, because, for example, they would give you a vaccine cost $200, and you give it to someone and they only reimburse you $6.40 for the vaccine, and they give you $12.30 for administration fee. It doesn't quite cover the vaccine itself. So what they did, the state has done, is actually they have made another fee schedule that actually is supposed to be able to go ahead and provide a better reimbursement rate to be able to cover those vaccines. Where most of the local health departments, they might still lose a little bit of money, but at least they'll be able to cover, for the most part, most of their vaccine, to be able to provide the services for all the people that are under out of Title 21. Again, which is Medicaid, which have to provide or pay for premiums depending on your income. Also, through our environmental health programs, we also...
Okay, Hector. I think I'm going to have to stop you there, all right? It's fascinating, and there is so much going on at the health department that I know we can talk about only that all night. And truly, with the funding, I can't imagine what this man goes through to keep things, all those balls in the air, so to speak. So, thank you very much. Okay, our next speaker this evening is Dr. Christopher Blandford. Dr. Blandford grew up in Wyanett, graduated, can you guys hear me?
Yep.
Am I doing this right? Okay. Graduated from Bureau Valley High School and attended Illinois College, graduating with a double degree in biology and chemistry. After graduating, he returned to the area and completed his EMT certification and briefly became the deputy coroner before being accepted to medical school at the University of Illinois, Rockford. While there, he was able to do additional training in the rural medicine training program called RMED. Is that how you guys do that? Okay. While there, he was able, he completed his residency at Genesis in Davenport and joined the Princeton Family Physicians Group 1 year ago. Dr. Blandford and his wife, Adriana, have a 2-year-old son and are expecting another child in December. Adriana teaches 4th grade at Bureau Valley North. So welcome, Dr. Blandford. Thank you so much for being here.
Thank you. Can everybody hear me? So thank you very much. Okay, there we go.
There you go.
Thank you very much for the introduction. So yeah, I just joined the team at Prairie last year, so it's definitely still wet behind the ears, trying to figure all this stuff out. Certainly, like our president said, nobody knew healthcare was going to be so complicated, something to that effect. I do have the benefit of not knowing any better. I started medical school in 2009, so that was right around the time that the Affordable Care Act was getting a lot of attention. I do also have the benefit of not knowing the glory days of just doing paper charts and everything being a lot easier. With that, I have seen a lot of changes just over my short time in medicine. Some of the biggest changes I've noticed, the first couple of years in medical school, when working with providers, I'd see a lot of people at the top of their chart, it would say self-pay. I've seen a lot less of that. I have very few people that don't have insurance. I think that's been one of the good things about the Affordable Care Act is that certainly costs have gone up, but I think a lot of that is associated with people that just didn't have any access to health care are now going in, which costs more, but those people are now healthier. I think Annette and Dr. Davis might talk a little bit more about things that are on the rise or up in the future. One of the things that is being talked more about is value-based healthcare. So looking more at the quality or how sick people are and the quality of healthcare that they're getting and reimbursing hospital systems and providers based on that. That comes with its own lists of pros and cons, but that's just kind of where everything's going. So I didn't have a whole lot else to say just because I'm kind of new to this, but kind of learning like you guys are as well. So thank you very much.
Thank you, Dr. Blandford. Interesting to get that younger perspective for sure for us older folks who've been around for a while, right? So, all right. Our next speaker here this evening is Annette Schnabel, and Ms. Schnabel has been the president and CEO of Prairie Memorial Hospital since May of 2016. She moved to Princeton in December 2014 as part of the hospital's CEO succession plan. She's been in the healthcare field for over 30 years, having begun as a physical therapist and in leadership roles for 20 of those 30 years. She earned her doctorate in physical therapy, holds an MBA, and is a fellow of the American College of Healthcare Executives. She has been a member of community and college advisory boards and is an active member in the local community as a member of Princeton Rotary, the Princeton Main Street Revitalization Steering Committee, the Pedestrian Bicycle Friendly Subcommittee, and the Z-Tour Planning Committee. On a personal note, Ms. Schnagel is married to Bill, a junior high school teacher, and they have 4 grown children. Thank you so much for being with us this evening.
Thank you. We've heard quite a bit of stories already tonight about how things got to where they are. So one of the things I'm going to talk about.
You're good.
Okay. Don't hear it back here. One of the things that was in the Affordable Care Act was a requirement for what's called a community health needs assessment. So hospitals are required to assess the needs of their community about every 3 years. And so this was done before I came, and so we did it again last year. And in doing that community health needs assessment, we invite multiple people to the table. So we had representatives from the health department, we had representatives from CPASA, we had chaplain people present, we had other community members present. And in that, we identified what are some of the needs in our community, and then from that we have to identify what it is we as the hospital are going to do to address those needs. So we look at, came down to some top priorities for the needs of this community. One of those is access to care. And so what does that mean when you talk about access to care? There's multiple definitions of that. One is, are there enough providers available to take care of the community needs from a health perspective? We heard someone else make a comment about the population, or I guess Pat made that about 20% of our population lives in a rural area, and that is true, but only about 10% of our providers provide care in that rural area. So we about have half the amount of providers in taking care of our rural patients as what they would have in an urban area. So that's one definition of an issue with access to care. Another consideration might be, is it available when I need it and where I need it? So can I get to that care? So again, in a rural area, you're dealing with things like transportation. Are they able to get to the appointment, and are the appointments when we can have them? So one of the things that we did from a couple of those perspectives, we have been trying to recruit additional providers to our community. And we have done that with the expansion of care with nurse practitioners and physician assistants. So when we again look at the physician access, not only do we have less in rural areas, but our nation actually is beginning to have more and more of a shortage. And as our population has aged and more need for that primary care provider, we're going to be experiencing more and more lack of providers available. So considering for us, what we did is we expanded hours, we expanded into additional communities, and we mixed more nurse practitioners and physician assistants into the care pattern. So we have physicians and nurse practitioners and physician assistants that are taking care of our patients. Part of that is we want to have people seeing the primary care providers, because that's the most important aspect of managing a person's health, is having that physician or nurse practitioner that is the center of the care with the patient. They help guide the care and manage the patient's care, and that we'll probably hear a little bit more about ACO when Dr. Davis talks about the work that he does with our Illinois Rural Community Care Organization, but helping to identify the best way to manage a person's care. And so one of the things is we don't want people to use the emergency room as their primary care site. That's not the best way to manage care. So again, increasing that access to care. So that's one thing we worked on. Another thing that was identified in our community health needs assessment is the need for population health. So we heard a little bit about that, again, across the panel here, but from our perspective, that is keeping people well, keeping them out of the hospital, and that seems like a weird thing to say as a hospital, but that's really, we need to think about it from when we look at the whole cost of healthcare, is we want to be in the prevention side and the wellness side, keeping people out of the hospital from that perspective. So for us, that's such things as nutrition, diet and exercise. So in my introduction, she mentioned several things that I'm involved in from an activity perspective, and I want to help promote that in our community, how to be more active, how to be involved in managing your health from that perspective. Also from the nutrition side, we have several activities that we do through the hospital. We do a Cooking with Ashley, Get in the Kitchen with Ashley class. It is, you can come every once a month and be taught how to do great recipes that are healthy, and you don't even realize you're eating healthy. We've also just recently started a diabetic education program. So we've had a diabetic support group, but we've actually enhanced that now with a diabetic education program with a nurse-managed program. So recognizing that we need to look at it from that perspective, what are those types of things we need to do? Another thing that came out in our community health needs assessment is access to mental health. And we are definitely not unique across this country in that need in our community. It is a major need across our country, and it's a very extreme challenge because, again, lack of providers that are able to provide that service, lack of providers available in a rural area, and the stigma of mental health, and the lack of funding for it. So they're really, it's a challenge for us from that perspective. So there are a lot of things we have begun to work on at the hospital in order to try to meet that. One is we do recognize the need to have partners for some of the work we do. So we do work with CPASA as from a prevention side when you talk about mental health with addiction issues. In our prompt care service, we actually do a treatment that helps people to become less addicted to heroin and other opioids. So that's a service we provide through that program. Last year we added a social worker to our clinic, and that person is able to work with our physicians and nurse practitioners to help patients to figure out what kind of resources they need to manage their health and to maybe even get them into other mental health services, but helps them get into that process. About 3 weeks ago, we started telehealth mental health services. So you can now come to our clinic. We have one night a week that we have a psychiatrist available to the community via telehealth. It is by appointment in referral, but that is, we have now expanded to bring that services available. Last year in August, we opened a program called the Senior Behavioral Wellness Program. This is, again, a geriatric mental health program in which we have, again, a psychiatrist available via telemedicine that will do the evaluation for the patient and set a treatment plan. We have counselors and group counseling sessions that are available. It's actually, they're at our facility for several hours a day. They get several group sessions. They may come 3 times a week, 2 times a week, 1 time a week, depending on what their particular needs are. So we've expanded that program. We currently have one of our nurse practitioners who's going back to get her additional education in mental health so that we, again, can expand what we're providing for our community. So there's a lot of things we're trying to do, but there's a lot more that needs to be done. You know, again, working through those kind of things. Another thing that was identified during our community needs health assessment was dentistry. We do not have a solution for that. We're hoping to work more with the health department and their program and see what we can do to help there. But we know that that's, again, need. Dental health actually affects your medical health. So it's important from that perspective. And then one of the other things that came up is people not even knowing where their resources are, what's available to us. So working on getting more information available to our communities about what is out there for us. So this talk is really about funding, so I want to talk just a little bit about some of the other impact that we've had at the hospital from the changes that are going on with the funding perspective. As was mentioned, more and more people are eligible for Medicaid through the Affordable Care Act and the processes that were put in place for that. And we all know how well our state has been doing the last several years. Currently, the state owes the hospital for services that's 220 days out. So most of us expect to be paid in 30 days for services when we are contractors or et cetera in our businesses. We're 220 days behind in being paid by the state for the services we provide to Medicaid patients. That puts a burden on us. At this point, it's a good thing for this community that Prairie Memorial is in a good financial position and can withstand from that. But there are many hospitals throughout our state that are very, very challenged by that. So it's not a good thing for us, but we're able to manage that at this point. About 14% of the work that we do is for Medicaid patients currently. About 45% of what we do is for Medicare patients. But the challenge, the other part of that challenge with us with the Medicaid patients is we actually get paid from the state about 20% of our costs for taking care of Medicaid patients. So we have to have funding from other ways in order to manage our business when we have that much Medicaid going on. So that again is a concern for us from that perspective. So just a couple other things to talk about from a funding perspective. One of the other changes that went into place recently is funding for physicians. They're on what's called a fee schedule, so if you do this type of service, you get paid X amount of dollars to do that. And there's not been a lot of focus on the quality outcomes specifically to care in the physician's office. One of the new things they put in place is called the quality payment program, which is now impacting the physicians as well. And I think Dr. Davis might talk about that a little bit more and how that fits into it all.
Thank you. Again, this is a whole lot to cover in a very short time. We appreciate all the information. Dr. Davis, last but not least. Dr. Davis is the Chief Medical Officer of the Illinois Rural Community Care Organization, a statewide rural accountability care organization comprised of 24 critical access and rural hospitals. As a board-certified family physician, Dr. Davis has practiced in rural Illinois for the last 36 years. He received his Doctor of Medicine from the University of Illinois, his MBA from the University of Massachusetts, and is also a fellow of the American Academy of Family Practice, a diplomat of the American Board of Family Medicine, and a nationally known speaker. Additional experiences have included service as the Chief Executive Officer and member of the Board of Directors of Prairie Memorial Hospital. In 2016, Dr. Davis was awarded the Rural Physician of Excellence Award from the Illinois Rural Health Association. He has also been honored for his achievements through the State of Illinois Senate Recognition Award and the House of Representatives 99th General Assembly House Bill 1436. Welcome, Dr. Davis.
Thank you. Thank you.
Right there, that's right.
Well, I wanted to start out by talking a little bit about...
Closer.
Okay, great, thanks. You can't, just tell me, okay. I wanted to start out by talking a little bit about, I think the thing that's really the underpinnings of this whole drive that we're seeing toward value, and that's the percentage of our gross domestic product that's being consumed in healthcare. The gross domestic product is the sum of all the goods and services that are provided or produced in the United States in any one year. If we go back to about 1965, when Medicare came on board, we were consuming about 5% of our gross domestic product, so that 5% of every dollar that was produced in goods and services in the United States was being consumed in healthcare in 1965. We're nearly at 20% now. It is also projected that if we remain on our current trajectory, that by 2040, 100% of our gross domestic product will be consumed in healthcare, which means there's nothing left. No roads, no schools, nothing. We're consuming every dime in healthcare. That's obviously unsustainable. And that's really the big deal that I think is the big change between 2020 and 1980. When 1980 came on board, we started seeing capitation in healthcare where insurance companies were really in a position where they were saying, we're going to pay X amount of dollars for you to take care of this group of, you meaning as a provider, to take care of this group of patients, all their costs. Well, at that point in time, we were around 10% of our gross domestic product. It could fail at that point, and it did. Capitation ultimately failed by about 1990 because it didn't have to survive. Because at a 10% consumption of our GDP, we could continue to sustain our economy. Well, if we're heading toward 100% of consumption of our GDP by 2040, obviously we are not in a position that we can any longer sustain that spending pattern. As a result, something has to change. And that's what led to the whole process of value-based purchasing, where we're at and where we're trying to move into now. The accountable care, or the ACOs, like which I'm involved with Pat, the whole concept there is to start looking at value. In the past, it's been the more you do, the more you get paid. It was fee for service, purely volume driven. By where we're going is value driven, so that it's the equation of is cost over quality equals value. So that what you're trying to do is drive cost down, quality up. Cost to reproduce or reduce cost. We're looking at certain things like Annette talked about, or somebody talked about the emergency room overutilization. If we look at our 24 hospitals and take a look at, through some algorithms that have been developed on the East Coast, you can basically say that about 50% of the people that walk in the emergency room of any of our rural hospitals don't need to be there. And when I say don't need to be there, I mean they could have been cared for in another facility, another setting that was more appropriate, more cost effective, and probably a higher quality of care because they'd have some continuity of care. Or their problem could have been prevented and they wouldn't even need to be there to begin with. So 50% of the people walking in the emergency room either could have been prevented or deferred to some more appropriate site of care. The resulting cost would be significantly less than what we're currently spending. The other problem that we're looking at is the issue of downstream spending. Pat and I have taken a look at recently at if you take a dollar being spent on healthcare in our rural communities, only about 20% of that is consumed at a local level. The other 80% is consumed at a tertiary care center. Like, well, an example, I'm not picking on them, but an example would be OSF, where they're providing super specialty care. That's been a big shift over the course of the last 30 years. When I first came, about 80% of the dollars that spent on healthcare were spent here in Princeton, and 20% were spent at a tertiary care center. It's flipped in that period of time. So we have a significant problem with where we're spending money at. And lastly is the issue of quality. How do we improve the quality? If we can improve the quality, we can improve the value. There's certain really neat things that are starting to happen, and that's for the first time, in my knowledge, in office settings, we're starting to look at comparing what we do against benchmarks. Now, in the hospital, that's been an ongoing process for probably 20 years, where we look at infection rates, catheter-associated rates, cardiac catheterization rates, coronary artery bypass rates. Those kinds of things have been evaluated. But in offices, it's really never been looked at until probably about the last 2 years. And now we're really starting to get an opportunity to look at how individual practitioners utilize and spend money and what kind of results they get, and comparing them against benchmarks. I'm done.
I would love to listen to you for all night, truly, Dr. Davis, since that is kind of one of my passions myself, having met Pat when I worked in quality improvement up in Mendota. So, all right, thank you very much. A lot of food for thought. We now have about 25 minutes for questions from the audience. Let's see what you've got. Yes.
Dr. Davis, could you tell me more about, in the last 2 years, what has been the change? Is it digital? Is that what's driving this? I mean, what's driving this new, what you were calling value-based metrics that we've got now?
The transformation to digital records.
That is mostly what it is?
Well, yeah, I think it's part of it. I mean, that was kind of the necessity. But I started with electronic medical records in 2000, and I can honestly tell you there was very little available until about maybe a year ago, that was really available to actually measure what was happening. Examples of what percentage of my population is women age, say 45 to 75 have had mammograms. What's my percentage of immunization rates regarding immunizations? How well am I doing as far as using anticoagulants with people that have arrhythmias? That was the kind of information that wasn't really able to be extracted until maybe about a year ago. Now we're starting to see that kind of information being able to be extracted from the electronic medical records. As you can imagine, you're talking about a paper record. It is impossible to approach that type of evaluation. I mean, industry for years has dealt with benchmarks, and how they do their production. That's never, those processes have never been applied to medicine until we're just on the cusp of that type of new things that are coming out. Really is exciting things as far as quality is concerned.
Great question.
Well, I'm glad to see that that's working, because I know as the offices the doctor's offices have tried to transition to that, there's been a lot of consternation on the part of the office workers trying to adjust. Every 2 or 3 years they come up with a different way of doing it or a different program, and having been a teacher, I know how much we always were changing right in the middle of, midstream. But you're seeing now where it's actually starting to work. It's actually starting to have.
I think we're at the beginning, but in the past it's always been, it was just about there.
Yeah.
We're actually there and just
Good.
starting now.
Good.
So,
That's good to know.
Good, great, thank you.
I would kind of second what he's saying, that we're just trying to get there. I'm an optometrist. I just, after 2 other programs that truly were shortening my life trying to do that, I've got a program that now I'm in the 2nd year of it, and I don't like to admit this too loudly, but I'm starting to be okay with it. That this is maybe a little bit easier, especially when you have a returning patient. You can see where they were last year, where they were this year. So department is getting used to the program and finding the right program that does work for you.
Software program,
Yeah,
correct?
yeah, I mean,
Yeah.
when we turned the page and just got a different vendor, got this 3rd vendor for it, staff was happier, I was happier, and we felt like we were moving forward rather than slowly dying. So sometimes it's a matter of getting the right software for it.
And being very nice to all your staff as they have to work through all of this, right? Okay, thank you for that. Who else?
I guess a couple things. For you, Annette, my cardiologist is based in Peoria. He comes up here and other places. I'm in Peoria a lot anyway, and it's just as easy for me to see him down here. Does it benefit Prairie for me to see him here?
Yes, it does, only because the more that they see patients up here, the more willing they're going to see patients up here. So there's a lot of people who can't travel to Peoria, and so we want them to have the volume that they need when they're up here. So that's the benefit. Now the other side is if they want you to get some simple labs, some simple diagnostic tests. If you're up here, you would get them in our hospital, presumably,
Right.
and therefore that would of course benefit us. So our preference is for you to see them in their community, in our community, if that works for you. Certainly there are times people are going to see in Peoria, but the benefit is that we want them to want to be here, and if they don't see enough patients, then they won't continue to come here.
Okay. Then for Dr. Davis, you talked about downstream expenditures, right?
Yes.
I'm not sure I understand that, but let me see if what I have in personal experience is an example. I'm on warfarin and have been for a long time, so consequently once a month I get a proton at Prairie. And I think though, isn't that lab work on that done in Peoria?
No, that actually is done here. Now, we have, our pathologist is based out of Peoria, so if you have the type of lab test where they take tissue and look at your tissue, that we transfer down to Peoria. But anything that's just a typical blood draw type thing, we process here at our hospital.
So downstream expenditures are because we're not capable of providing a service here?
Correct.
Okay.
It
No,
may
not
be,
totally.
Well, yeah,
well,
I was
yeah.
gonna say.
Some of it's about choice, about people choosing to go there, but, and then some of it would be because they need that higher level of care. So it's a mixture of reasons.
Okay.
I'll go one step beyond that, though. There's also a waste, there's, the other component of downstream spend is waste. An example would be duplications. And we see that fairly frequently, where, you know, a test may be done here at Prairie, and literally 24 hours later, it's duplicated in a tertiary care center.
Because you see another doctor and he doesn't want to use the test you had elsewhere?
Well,
That's happened.
there's several reasons. I mean, one is that they understand the quality of the test is done in their own institution, and they feel more comfortable with that. That's number one. Number two is when you order a test down there, it's read by the guy down there, which means I, as a physician that practices on their staff, an example, I can walk in now and talk to him about that test. The radiologist that read the test here is here, okay? And it's gonna be hard for me to access. And the other thing is just simple workflow. I mean, in my training, and I'm sure Dr. Blandford probably seen this too, is that frequently what you'll see is that, you know, a doctor will walk in, will be presented with a particular problem, and he will start into his algorithm and kind of in his brain that I do this, 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 and this. What you don't do is say, well, this has already been done. I don't need to do that. It just flows out. And the result of that flow means that if the guy before you in Princeton did it, it probably is going to get ignored.
But I wanted to add to that is that, you know, with that, if we use our electronic medical records and we do a better job of managing our local doctors and nurse practitioners and PAs, talk to those specialists, we can communicate that. Because that's going to be important, because in the future, there's going to be more cost out of pocket to people for all the duplication of tests coming down. That's where we have to be concerned about, is that eventually so we want to really kind of plan your care better, so you don't have to pay 2 or 3 times for that.
Right.
And that's what we're working hard. There is something about, you know, running your routine of knowing that you've covered everything, but on the same time, we have to use our communication tools and learn how to better talk to each other, get the information, so we can make better decisions to provide more complete care to you and not have it cost so much money.
So from our perspective, there's two pieces that I want to speak to. One is, as you as consumers have to know what you have had done and be willing to say to a specialist, I've had that done, get the result, I'm not doing it again. So you have that power, you have that right. There has been a atmosphere in healthcare that's very patriotic.
Yep.
That's the word I'm looking for. Patriotic. That the doctor said it, so therefore I shall do it. And we need to actually, as consumers, be willing to say, no, I've done that, let's get the result, I'm not repeating that. And we've, in the past, not been willing to do that. The second piece is you asked the question about electronic medical record and this communication issue. We are in the process of changing our electronic medical record as well. We have had ours for 17 years, and it does not communicate well with the specialist. So we are getting a new system that will communicate better so that the people can have better access. It is an expensive endeavor to do this. It is a timely endeavor. We will not go live with our new system until May 21st. We've been started the journey in June. It's a huge effort and it takes a lot of work, but in the long run, we know it's going to be better for our community, so we're doing that investment.
One of the misconceptions that gets brought up quite a bit is that it's in my records, it should be in my records, and the records from Prairie Memorial to OSF to that one time you were in the ER in Florida, nobody really talks to each other as easily as you might think, and so that's why a lot of tests do get repeated, because I can't find it, let's just repeat it real quick. It's better to have a more up-to-date one, you know, just those types of thoughts get brought up. So that's why there is a lot of duplications of tests, and ideally, it would be great if they all just talk to each other, and if you had one test drawn somewhere, you could just pull it right up, but unfortunately, that's not where it is yet.
One thing I wanted to say, I don't need that. Is being a veteran from the armed forces for 27 years, I also go to the VA. What the VA has done over the years, even though some of it has been pretty bad, is each one of those facilities, clinics, the hospital, have access to your records. So they're able to go ahead and see, okay, you had this done, okay, this looks good, we can go ahead and continue on the thing. Whether it is mental health or for medical care, they're able to see that. So.
The VA is actually one of the best examples of electronic medical records in the nation. And the sad thing is they're getting ready to change. But they're going to the same thing we're going to, so that's the good thing.
And interestingly, they were one of the worst examples of a paper chart.
Yes.
Yes,
In the
they
United
would
States.
always lose it.
It was awful. It was impossible.
And the VA negotiates with pharmaceutical companies, right?
Yes.
Yeah.
Whereas no one else does.
I have a couple questions. What are the low-hanging fruits that you all, from your own perspectives and together, can say, right now, if we say, I'm your fairy godfather, you get what you want, what's going to make a difference right now? Start with that.
ER visits, I think, are probably the biggest ones. One of my medical student friends, his project, his 4th year over at Spring Valley actually was, he would interview every patient that came into the ER when he was there and ask them why they went to the ER versus going to their primary doctor. One of the things that he found, and he was kind of surprised at, is they just couldn't get into their doctor. And so that's a big portion of that, and one of the things that we've done in our clinic recently is we're trying to have one of our nurse practitioners be the same day person. So if somebody has a problem that, they have a urinary tract infection, or they've got a really bad cold or something, they need to come in right now, but, I'm already all booked up for the day. They can come in and see this provider, get this easy problem fixed, and, maybe save. A urinary tract infection in the ER is a significantly higher cost, even though everything else is done the same, and you probably spend actually more time in the ER trying to get that done. So I would say the ER visit's probably the biggest one.
Good.
I think one of mine would be mental health. When we take a look at all of healthcare and the expenditures and the challenges we have, mental health is huge, and because it impacts everything. Not only does it's about your social and et cetera, but when you have mental health issues, you also have physical health issues. They come together because of the challenges of mental health. So having better access to mental health and the societal aspect of it is one of the things I would love to see us have more opportunity for improving in.
That's great. I'm excited to hear that you've got telehealth up and running now with that. So is the reimbursement there where this can be sustained?
So one of the things that is available, and I didn't talk about this when I was talking about the different reimbursements, but there is a special classification for clinics that is called rural health. And we have our Paramount Family Health Clinic, and now just recently our prompt care has been designated as rural health clinics. Rural health clinics are paid a little bit better from both Medicare and Medicaid than a standard clinic. And telehealth is reimbursed in those locations because you're rural health. So our psychiatrist that will see you when you come to Paramount Family Health Clinic is actually in Florida. But she's right there on the screen, and she's able to interact with you, so she's able to take care of you. But and that'd be another, probably one of those magic bullets I'd like to see more of, is telehealth. Not all insurance companies pay for it, but Medicare does, Medicaid does, especially when you're in a rural health clinic. There are some insurances that do. It would be nice to have more of them paying for that, because again, in rural areas, you wouldn't have to travel to Peoria to see that specialist if we could do a telehealth visit. It would reduce some of that problems as well.
I think care coordination actually is one of the low-hanging fruits. The problems that people encounter going through a continuum of healthcare, where they may start with a nurse practitioner and wind up with a super specialized neurosurgeon, and everything that goes in the middle. It's that stepping through the healthcare system that is incredibly complex, and unfortunately, it also is very inefficient, and also frequently allows people to make errors and not get to the places where they need to be, resulting in poor outcomes, resulting in higher costs. We're starting to look at, how do you coordinate those transitions? And with the coordination of those transitions, you can reduce both the opportunities for errors in the process, and you can also reduce the cost associated with those errors. So I think care coordination, and we are really looking at how do you implement that. There's other components like case management, where you're making sure that people, in a particular problem, get through that process in the most efficient manner, which I think is also a cost savings. And the last cost savings that I'll talk about, which also flows from this, is what I call gap closure. And that's the issues of usually preventive health care that doesn't get addressed in the course of a routine office visit. There's a significant amount of that is falling through the cracks throughout our entire healthcare system that results in a lot of disease processes that could have been prevented or seen earlier. And it's very difficult to deal with that under a fee-for-service structure.
I read an article yesterday that typical family practice physician has about 2,000 patients. I don't know what you guys exactly have, but this is just a study that was done. About 2,000 patients. If they were to do everything for all 2,000 patients that they should do, and to be able to manage that, they'd be working 17.4 hours a day. I don't know if either one of these guys wants to work that many hours or not.
You don't need to sleep,
I
do
kind
you,
of
right?
routinely say that in my office, the average patient that walks through the door has 3.5 complaints.
Okay.
I think there's
Pat,
one
you had-
issue
yeah.
that we need to bring up that's a low-hanging fruit, that's not necessarily here at this table, is people being responsible for their health. And, Dr. Davis talked about being able to see into the patient records and learning whether somebody had a mammogram or how they're taking care of their diabetes. We really need you all to do a better job of helping take better care of yourself. If you're under care for diabetes, are you eating right? Are you exercising, taking advantage of these programs? Because we can't fix it all ourselves. I mean, healthcare workers can't do it. We need you. We need to be able to cooperate and love to hear your ideas, how we can do a better job to communicate with you. Because that's really about it, is we're all taking some ownership, just like in education. A student still has to learn themselves, but how can we help you do a better job? That is one hanging fruit that we really didn't talk about.
Accepting that, what about that, whatever percentage of the population it is, that are not able to understand or act on what they need to do to be healthier
And we
people?
need to be better stewards of it.
So we're talking 30% or more don't read above an 8th grade level. Many people are so incapacitated by depression or anxiety or their life situation, they cannot make a decision. I mean, all of us go through that. When I see my stack of literature on my choices for health, which is many too many choices for me. So what you are faced with this every day, it's got to be a psychological and an emotional decision, as well as a medical and an economic one. Because the very people whose co-pays, they're making higher and higher, they're not going to cover that, are going to show up at your door and you're required to treat them. How do you deal with that? And lastly, who do you know who's dealing with that better than all of us? Because that's a wrenching equation, I think, for us as a culture and every single day when we treat anybody, is what about those people who cannot take care of themselves? What do you do?
I have a challenge for you. First of all, that perhaps that's one of our next panel discussions, is exactly what you're talking about here and how we do handle those sorts of things. We have about 5, and you guys all think about that for the next time you come over, okay? We have about 5 more minutes. This is on funding, and Stephanie has a specific question she would like to ask the panel regarding that and legislation, so I'm going to give this to Stephanie. Okay.
I'm trying to word this without saying you need to go to your crystal ball. We've been faced now with this bipartisan bill that is being discussed. If things go through and it does not happen, and the ACA stops functioning the way it has, and right now there is nothing in place to kind of cover that situation, how will that impact us here?
So right now, with the executive order that Trump did this past week by eliminating the cost share reductions that go to the insurances, the anticipation is that for the first year it probably won't affect anything, but then after that it will. So then the insurances will probably reduce the amount of locations. Again, and from a rural perspective, as Pat had talked earlier, there's a lot of counties that don't have an option for that program in the exchange. So that is an anticipation that could happen, that if the cost sharing that was being given to the insurance companies is not get reinstated somehow, that those could start going away, and there will be less people that will have that coverage. So that would be a problem for us, and because right now we do already have limited number of options available to us anyway in the exchange. One thing that I, again, read yesterday I thought was interesting is that in the state of Illinois, they decided that Ronner had a crystal ball, because he went to the insurance companies and encouraged those that had a silver plan to up the rate of their silver plan. Because the other side of it, there's the cost share savings that went to the insurance companies, but there's also the tax break that went to the people who qualified for them in the exchanges. And if the higher your premium, the greater tax break you got. So if you are eligible for the tax breaks and you take the silver plan, you'll actually get a better tax break right now in the state of Illinois because of the work that they did ahead of time.
The other thing is the uncertainty of Medicaid. We don't know what's going to happen. And yes, we've expanded it in Illinois. They continue to grow it. We can't even pay our own bills here. So how do we sustain that? That's a problem. And what happens, instead of trying to take care through doctors' offices or other place like that, they're back in the emergency department. Because that's how we've taken care of public aid, Medicaid patients for years, is the emergent, and then they're not staying healthy, and we repeat the cycle. So that's the challenge, really.
And the result is quality goes down and cost goes up.
Yep.
And they cycle in and out. Pat and I looked at the high frequency, the frequent flyers across the state of Illinois, and we've seen patients that have gone to the emergency room 145 times in 1 year.
Oh my God.
Yes.
It's not unusual to see 50 times a year.
I'd like to stop us here because we are out of time. However, if our panelists are willing and they want to spend a few more minutes, for those of you who'd like to come up and thank them personally and maybe see if we've got another question, we could certainly do that. This has been wonderful. Thank you all very much. And thank you, audience, for being here this evening. And let's give our panelists a hand.